Okay, awesome. So we'll get started today. Good morning. I wanted to start you off today by telling you a story. It starts around when I was 13 years old. My dad had been feeling unwell for around 2 weeks, so we went to our local emergency department. His heart rate was fast and his blood pressure was low. This was the first time that I heard the words atrial fibrillation. The doctor's urgency to slow his heart rate down seemed to make sense at the time. Within 24 hours, he was being flown by Orange to a cardiac ICU in Toronto. At the time, I saw this as part of a disease trajectory. It was not until a few years later that I learned about the term tachy-induced cardiomyopathy. I learned that the treatment was not to slow down the heart rate, but instead treat the underlying the heart failure first. As I've progressed through the last 5 years of residency, I realized that we have a tough job as emergentologists. What is often seen as a source of pride in our role as diagnosticians is the same role that increases our potential to make errors due to our lack of information in a time-sensitive environment. But we do have tools that can make us a little bit better at our jobs. One of these tools is POCUS. If the physician who had saw my dad many years ago had used POCUS, he may have seen a dilated LV and a severely reduced heart function. He may have thought twice about giving him beta blockers. I tell you this story, while anecdotal, to hopefully convince you that our use of bedside ultrasound has the ability to not only change our diagnostic capabilities and improve them, but also to change patient outcomes. My name is Nate Murray, and today I want to talk to you about probing the evidence, POCUS articles to change your practice. My supervisor today is Dr. Rajiv Tavanathan. I know some people may be cringing at another POCUS talk today, but I promise that everything that we talk about today can be done with a level 1 and 2 skills. To develop this talk, I went through all of the POCUS papers that were published in the last 12 months, and believe it or not, there was over 1,500 titles. I tried to choose the top articles that I thought would be most relevant to the everyday emergency provider's practice. In an ideal world, you would take everything that you learn about today and apply it to your next shift. But I know that that's probably unrealistic. My goal by the end of this talk is to try to convince you of the evidence and clinical utility so that you feel comfortable applying one or two of the things that we talk about today to your next case. A quick disclaimer, these views and my views of the articles and their importance to clinical practice are partly my own. I recognize that POCUS articles are generally smaller and suffer from common methodological issues such as selection bias from convenient sampling, leading to concerns about generalizability. That said, POCUS training is now embedded in medical school and residency education. It is no longer unique to our specialty and now is becoming a cornerstone for clinicians in a wide variety of specialties, from internal medicine to nephrology, cardiology, respirology, urology, and so on. POCUS has become an integral part of our practice here locally as emergency physicians. Most of the de-identified images that you see today are taken from clinical cases that we're seeing on shift in our own department. I think it's important to highlight, while these images may not be perfect textbook views, they were able to answer clinical questions, aid in diagnosis, and improve patient outcomes. As I progress through the talk, please keep an eye out for this logo that indicates the physician that performed the POCUS exam. Today, we'll meet 5 patients you could very well meet on your next shift. The first one is a 55-year-old male in cardiac arrest, a 54-year-old female with hypotension, a 65-year-old male with pleuritic chest pain, a 24-year-old female with a skin infection, and a 22-year-old female with dyspnea. The articles that we talk about today will be very relevant to their presentation. So let's meet our first patient. Our first patient is a 55-year-old male who presents with witnessed out-of-hospital cardiac arrest, and he presents with CPR ongoing. At the first pulse and rhythm check, you try and feel for a pulse. A second MD is taking a look at the heart in the subxiphoid region. Despite your best efforts, the only pulse you feel is your own. Your end-tidal CO2 monitor is being finicky, and you wonder if this patient in front of you has ROSC. You resume CPR, and you wonder what is the best way to check this patient's pulse at the next pulse and rhythm check. This paper, published in the last year by Haddad et al., helps to answer that question. I'll pause for a second because if you think I broke my promise to keep this talk basic, I promise you that pulse wave Doppler is very simple. You simply put the linear probe in the inguinal region and center the femoral artery. You then hit the pulse wave Doppler seen in the red box on the screen. There's a closer look of the pulse wave Doppler button on the Sparks machine seen in the bottom right-hand corner. After hitting the pulse wave Doppler button, you should get a screen that looks something like this. You then move the pulse wave Doppler indicator or gate over the artery before hitting the pulse wave Doppler button again to get the arterial tracing. Your screen should now look something like this. You can adjust the baseline and scale seen on the sliders to the left to try and maximize visualization of the tracing to get the peaks, but the peak systolic velocity is simply the top of the peaks of the tracing. In this case, you can see that it's well over 30 centimeters per second. I promise you, if you can use M mode, you can very likely use pulse wave Doppler. So let's get back to the study. This was a secondary analysis of a previous study among 80 cardiac arrest patients that defined ROSC as a systolic blood pressure greater than 60 millimeters of mercury. They found that femoral artery Doppler was more accurate than manual palpation for detecting any pulse. I'll say that one more time. They found in this study that femoral artery Doppler ultrasound was more accurate than palpation for detecting any pulse. When they used a cutoff value of peak systolic velocity greater than 20 centimeters per second, they found that it was more accurate at detecting ROSC. This study included patients over the age of 18 who sustained out of hospital or in hospital cardiac arrest. They were all mechanically ventilated and all of them had femoral artery lines placed. The authors then recorded concurrent readings of the highest systolic blood pressure on art line, the highest blood pressure on art line, the highest peak systolic velocity on Doppler ultrasound, as well as the highest end-tidal CO2 recorded at the end of pulse check. Their primary outcome was to see which one correlated better. Was it peak systolic velocity to systolic blood pressure, or was it end-tidal CO2 to systolic blood pressure? Their secondary analysis was to see which more accurately predicted ROSC. So again, that's a systolic blood pressure greater than 60 millimeters of mercury. Was it peak systolic velocity greater than 20 centimeters per second, or was it end-tidal CO2 greater than 20 or 25 millimeters of mercury? If you're wondering why they use the end-tidal CO2 cutoff of 20, you'll remember that the AHA guidelines recommends an end-tidal CO2 target during CPR of 10 to 20 millimeters of mercury. Recent literature has shown that end-tidal CO2 greater than 20 to 25 to be consistent with ROSC. A recent study by Krieger in 2021 found that end-tidal CO2 greater than 20 millimeters of mercury was highly specific for ROSC in PEA patients. So what did the study find? There were a total of 35 patients and 111 pulse checks that were analyzed. Peak systolic velocity was found to correlate better with systolic blood pressure than end-tidal CO2. Looking at the test characteristics, if you look at the first and second column of this table, you'll see that Doppler ultrasound using a peak systolic velocity cutoff of greater than 20 centimeters per second outperformed end-tidal CO2 greater than 20 millimeters of mercury in detection of ROSC for all test characteristics. When the end-tidal CO2 cutoff was raised to greater than 25 millimeters of mercury, the specificity was the same as Doppler ultrasound, and positive predicted values and positive likelihood ratios, although different values, these values were not found to be statistically significant. The study was quite strong in terms of its methodology. Treating teams were blinded to the ultrasound results, and they ran a quite rigorous statistical analysis with provision of test characteristics. The study is slightly limited in that Doppler ultrasound was performed by trained providers. That said, as we mentioned before, it's pretty easy to learn pulse wave Doppler. And this study contradicted many previous studies in three important ways. The first way is that there was higher rates of ROSC in the study compared to other studies. One explanation is that you could imagine that providers, if they placed a femoral art line and intubated the patient, these patients were probably more likely to have a greater chance of survival or greater odds of survival at baseline. The second was that the CO2 was checked at the end of pulse checks, whereas most prior studies in resuscitation literature would check CO2 during CPR or with CPR ongoing. And there was a higher proportion of patients with PEA arrest. And this is important because we know that end-tidal CO2 can be influenced by lung pathology, and patients with PEA arrest are more likely to have lung pathology. In addition, we don't know if the peak systolic velocity differs for patients with shockable rhythms or patients with PEA. Now, this is one study, so by no stretch of the imagination am I suggesting that we should abandon end-tidal CO2 in place of the femoral artery peak systolic velocity. But certainly, there's convincing evidence that manual palpation is not the best test to determine ROSC. Now, let's say I've convinced you that POCUS is better at determining ROSC than our standard methods, but you don't feel comfortable with this whole pulse wave Doppler business. I want to draw your attention to this article published in 2022. This was a blinded, prospective, single-center study that used an easier method for checking the pulse. Essentially, the authors used ultrasound probe to compress the neck until the internal jugular vein completely occluded, and they watched for carotid artery pulsation, which you can see in screen left. They found that this method shortened the time for pulse checks compared to manual palpation, and this method never exceeded 10 seconds. The number of patients who required a pulse check lasting more than 5 seconds was significantly lower for the carotid artery compression group than the manual compression group, 5 patients compared to 37 patients. This difference was found to be statistically significant. In summary, the best use of your fingers during a pulse check is to hold the ultrasound probe. Let's meet our next patient. Our next patient is a 54-year-old female who presents to the emergency department with hypotension and shortness of breath. You put your probe on the IVC as part of the rush exam, and you wonder if you should give this patient a bolus. This paper, entitled Shock IVC, was published by Dunfield and colleagues and may help to guide your decision. To give a little bit of context, if you've been around the POCUS world for more than a few months, you know that evidence for IVC is conflicting. Previous studies looked at mechanically ventilated patients, and evidence about using IVC to guide fluid administration has not held up. One of our intensivists, Dr. Scott Millington, wrote this reflection in 2019, highlighting some of these issues. The Shock IVC trial was based on the multi-center international Shock ED randomized control trial, which is one of the most rigorous POCUS articles that's ever been done to date. Spontaneously breathing patients in shock were randomized to either receive early point-of-care ultrasound plus standard of care or standard of care alone. The Shock IVC trial was a post-hoc secondary analysis of the data from the Shock ED trial. In total, there was 138 patients that were randomized to the POCUS group. The authors collected data on IVC size and collapsibility, and then independently assigned fluid status determination from a blinded chart review, which was used as a reference standard. The primary outcome was to see if IVC ultrasound measurements of size and collapsibility could identify patients with shock who were volume overloaded on the initial presentation. In total, there was 137 shock ED IVC scans that were performed. 8 of them were indeterminate and disregarded, leaving 129 scans that were determined in terms of IVC size and collapsibility. They ended up with a total of 125 patients in their final analysis, as 4 patients lacked enough data from their chart review to determine fluid analysis. So what were the results? Out of 125 patients included in the study, 84% were volume deplete, 10% were euvolemic, and almost 6% were volume overloaded. When they looked at POCUS findings separately, they found that dilated IVC greater than 2.5 centimeters had a sensitivity of 100% and a specificity of 95% for predicting fluid overload. When they looked at collapsibility on its own, they found that it was less reliable as an independent measure with a sensitivity of 85% and a specificity of 47%. In terms of IVC and collapsibility, they went through 4 different combinations of normal and dilated IVC, as well as no or minimal collapse. And they found the 2 combinations with the highest rule-in value were normal IVC, so that's 1 to 2.5 centimeters, plus no collapse, had a specificity of 94%, almost 95%, and dilated IVC greater than 2.5 centimeters, plus no collapse, had a specificity of 91%. The study was quite strong in terms of its methodology. The data that they used was based off of a multi-center international randomized control trial, and fluid volume status was done completely blinded to the ultrasound results. The primary outcome also targeted the highest risk patients, those patients who present to our emergency department who are hypotensive, in shock, but are in fact volume overloaded. The limitations of this paper is that it was retrospective, and I will say that it was underpowered. So from their calculations, they determined they would need 100 patients, with approximately 20% of them not needing any volume resuscitation. And in the study, only 16% were either euvolemic or hypervolemic. They also didn't report the inter-rater reliability. And this is important because we know there's no true gold standard to determine volume status in a patient, despite what internal medicine tells us about our JVP. So how do I recommend that we apply this paper to our practice? While the study was underpowered, I think it provides an important data point to our use of IVC in assessing patients presenting to our emergency department in shock, specifically those who are in fact volume overloaded. My recommendations would be to strongly assess the use of fluids in your hypotensive patient presenting with either a dilated IVC greater than 2.5 centimeters or a normal sized IVC plus no collapse. Use this in addition to your physical exam and other POCUS findings to protect against harming the small subset of patients who do not benefit from additional fluids but are in shock. Just a quick plug for POCUS. You'll remember that 94% of the scans were determinant for IVC assessment in these patients presenting with shock. Let's go see our next patient. Our next patient is a 65-year-old male who has a past medical history of COPD, who presents with pleuritic chest pain, hypoxia, and hypotension. You bring your ultrasound to the bedside and you perform a POCUS. I want to pause for a minute for you to do a quick interpretation in your head of the images. Hopefully it's easy to see in these images that the RV is large and you should be worried about signs of RV strain. As emergency physicians, we often have a clinical dilemma of whether the patient in front of us has RV strain presentation secondary to an acute or chronic process. We know that the workup and management are different for these 2 presentations. Does this patient in front of us today have a PE or just pulmonary hypertension? Are there any clues that can help to guide our decision? This is a narrative review published by Allerhan and colleagues in the last year that helps to answer this question. The authors performed an extensive search strategy of PubMed and Google Scholar using search terms such as right ventricular dysfunction, RV strain, POCUS, pulmonary embolism, and pulmonary hypertension, and so on. They also looked through all of the references of every article that they found to look for new articles. They restricted their search to English language studies, and they selected them by independent analysis first and then consensus. Their criteria were inclusion of pathophysiology, reference of cutoff values, data for given echo-radiographic parameters, and they preferentially selected the highest forms of evidence, starting with randomized control trials, then prospective studies, then retrospective studies, and then reviews. Summative ranges reported were derived from the minimum and maximum values obtained from the literature. The study's greatest strength is its use of its intense search strategy. This is the best summary of evidence that we have to date. There was over 175 references used with priority placed on the highest forms of evidence. The study is slightly limited, like most narrative reviews, in that there is some publication bias, and it was limited to English articles. The authors looked at 8 findings you could very well see with POCUS that may indicate PE versus chronic pulmonary hypertension. We'll only be talking about 4 that are within the scope of level 1 and 2 skills. We will not be discussing tricuspid regurg, pressure gradient, pulmonary acceleration time, the 60-60 sign, or pulmonary artery early systolic notching. If you want to learn about these, do a POCUS fellowship. These are the 4 POCUS findings that I think are most relevant for the middle of the pack POCUS user. First is the presence of right heart thrombus. The second is right ventricular free wall thickness. The third is McConnell sign. And the last is right atrial enlargement. We'll first talk about right heart thrombus. Right heart thrombus appears as a long, thin, free-floating worm-like mass on the right side of the heart. It's differentiated from vegetation or tumor in that it's not attached to any valve. The sensitivity and specificity that the authors reported were based on systematic reviews and meta-analysis. They found that the specificity was 99 to 100% for diagnosing pulmonary embolism, with a very low sensitivity and a very low prevalence rate. The prevalence rate increased slightly in hemodynamically unstable patients and patients in the ICU. The next finding to differentiate PE from chronic pulmonary hypertension is RV free wall thickness. It's measured at the end of diastole, so just as the tricuspid and mitral valve leaflets start to close. And it's where the tricuspid leaflet tip comes close to the wall of the RV. It excludes any trabeculae, pap muscle, or epicardial fat. You can see how to do it with the POCUS 101 diagram there. With acute RV strain, the RV has not had time to adapt and hypertrophy, so the RV dilates and stretches with a thin wall. The authors found that the RV free wall thickness on the subxiphoid long axis, so one of our basic level 1 views, range from 3.3 to 4 millimeters in normal healthy physiology. In chronic RV dysfunction, they found that the range was from 5.6 to 11 millimeters. In patients who had chronic RV dysfunction, the sensitivity and specificity was based off of patient databases. They found that the RV free wall thickness was 90 to 93% sensitive and 94 to 95% specific for diagnosing chronic pulmonary hypertension. Next, we'll talk about McConnell sign. There are a few different proposed mechanisms for McConnell sign. I think the easiest one to understand is that in acute PE, the RV balloons out, but the apex, being still feathered to the LV that is usually hyperdynamics, gives an appearance of hypokinesis of the free wall with a hyperdynamic apex. In chronic RV dysfunction, the RV is so hypertrophied that it is not as easily pulled inward, so you don't see a McConnell sign. The authors found, based off of systematic review and meta-analysis, that McConnell sign was 97% to 99% specific, but only 22 to 29% sensitive for the diagnosis of PE. Both sensitivity and specificity increased the more proximal a PE was. The last finding we'll discuss from this paper is right atrial enlargement. In normal physiology, the RA is normally a little bit smaller than the LA, so the RA to LA ratio is less than 1. In acute RV dysfunction, the RA will dilate, so the RA to LA ratio becomes equal to 1. In chronic pulmonary hypertension, the RA dilates further, causing the RA to LA ratio to be greater than 1. After reviewing studies looking at survival outcomes from patient databases, the authors found that the mean RA area to LA area for acute PE was 0.97 to 0.98, and for chronic was 1.3 to 1.5. So just a quick word of caution. I'll just do a quick pause. I want to caution you that patients with underlying RV dysfunction and chronic pulmonary hypertension who present with a significant change from baseline can have a pulmonary embolism. This is a case from our shop a few weeks ago. This patient had known underlying lung disease and presented short of breath with increased O2 requirements. You can see here that the RV free wall thickness is greater than 5 millimeters and the RA to LA ratio is greater than 1, suggesting that this is a chronic process. The provider quickly recognized a clot in the RA. If you look back at the literature for this article, there are instances where the RA to LA ratio was greater than 1 in acute pulmonary embolism. I think this paper is important to highlight because just looking at the infographics, which have been floating on FOAMed everywhere, in this article, it can be easy to make the false assumption that these findings of acute versus chronic right heart strain rules out a PE, when in fact, they only have specificity to rule in a pulmonary embolism. Other than perhaps right-sided thrombus, you cannot use one thing in isolation to determine whether or not the RV changes you're seeing are from an acute or chronic process. Right heart thrombus and McConnell sign have the highest specificity and should be used as rule-in tests for pulmonary embolism. There is a caveat in that McConnell sign is not specific for PE alone. It can also be seen in RV infarct, so just be cautious of that. Although the sensitivity and specificity for RV free wall thickness are both high for both chronic pulmonary hypertension, it neither rules in a PE or rules out a PE. As we saw from our previous case, a PE can present both with a chunky RV, but if you see a thin RV and other secondary signs of acute PE, you can consider that a chronic process is less likely and chase the acute cause. The same is true for right atrial enlargement. All right, so we'll go take a quick break and then go see our next patient. Our next patient is a 24-year-old female, immunocompetent. She's presenting to your emergency department with right thigh pain, swelling, and fever. This is one of the nastiest cases of cellulitis you've ever seen. So you bring your POCUS to the bedside and you wonder if your POCUS findings can help you in the diagnosis of the more sinister infection of necrotizing fasciitis. This was the first of 2 papers published in 2023 on the use of ultrasound in the diagnosis of necrotizing fasciitis. While there was overlap in the 2 papers regarding 3 larger studies, this specific paper included in their analysis case reports that exist in the literature. The authors performed an extensive literature search with stringent inclusion and exclusion criteria. They had 2 independent reviewers with a third to settle discrepancies. They found a total of 21 studies that met their inclusion criteria, including 3 observational studies and a cumulative total of 21 cases from a combination of case reports and case series in the literature. I put an asterisk beside the 3 observational studies, as we'll talk about them when we talk about the next study. They found the most commonly used probe to diagnose necrotizing fasciitis was the linear probe. The most common findings on ultrasound in case reports was fascial fluid, with reported in 17 of 21 cases. Subcutaneous thickening and air tied for the second most common finding, seen in 13 out of 21 cases. The strengths of this study is that it included the highest quality of evidence in addition to case reports. It's limited by its search of only English papers and again, publication bias, and much of the conclusions were based off of case reports. This is a second paper published in 2023 looking at the use of ultrasound for the diagnosis of necrotizing fasciitis. The authors performed an extensive search strategy using multiple research databases. They adhered to the PRISMA DTA guidelines, and there was 2 independent reviewers with a third to settle discrepancies, and articles were graded for the risk of biases. In total, 867 papers made the initial first pass, and then from that, 3 studies were included after they went through their inclusion and exclusion criteria. 3 studies were included in the qualitative analysis. There was 1 American study and 2 studies from Taiwan. In total, 221 patients were included in their qualitative analysis, 33% of which had necrotizing fasciitis. They found that the sensitivity for diagnosis of necrotizing fasciitis with the use of ultrasound was 85 to 100%, and the specificity was 45 to 98%. In terms of specific characteristics, only one study looked at this. Lin in 2019 reported the accuracy stratified by individual ultrasound findings. Fluid accumulation at the fascial layer was most sensitive. A previous study also demonstrated that the presence of subcutaneous thickening and fascial fluid greater than 4 millimeters was 88% sensitive and 93% specific in the diagnosis of necrotizing fasciitis. Subcutaneous emphysema was the most specific with 100% specificity. You'll remember from our previous study that we talked about that fascial fluid and subcutaneous air are two of the most common findings that we see in necrotizing fasciitis. The strength of this paper are its extensive search strategy. They also screened each article for the risk of bias. The three studies, it is limited somewhat in that the three studies used in the final analysis had convenient sampling. All of them used slightly different diagnostic criteria to define necrotizing fasciitis on ultrasound, and there was an unclear level of blinding. So let's take a quick look at what this looks like on ultrasound. We know that soft tissue infections exist on a spectrum. To the left-hand side of the screen, you see normal subcutaneous tissue with well-maintained tissue architecture. As infection forms, the subcutaneous tissue architecture is lost, and you start to see fluid that accumulates between the tissue. You start to see thickening with some cobblestoning. In more severe infection, you can begin to see fluid along the fascial planes, as well as dirty shadowing caused by subcutaneous emphysema, which is represented by hyperechoic foci in the subcutaneous tissue with dirty shadowing behind it, which you can see with the red arrow on screen left. Here's another labeled diagram of what fascial fluid looks like on ultrasound compared to the normal side on the left-hand side of the screen. So in summary, to date, this is the best evidence that we have regarding the use of POCUS in the diagnosis of necrotizing fasciitis. POCUS was significantly more sensitive than fever, hemorrhagic bullae, or hypotension, and the sensitivity rivaled that of CT scan. So I recommend if you have a patient with severe soft tissue infection, you take your linear ultrasound probe. If you find subcutaneous air, this is often a late finding and is the most specific finding for ruling in the diagnosis of necrotizing fasciitis. As you scan, you're more likely to see fascial fluid. If this is more than 2 millimeters, you should strongly consider the diagnosis. But if it's more than 4 millimeters combined with subcutaneous thickening, this is highly specific for the diagnosis of necrotizing fasciitis. Just another plug for POCUS. If you think you are underqualified for the use of POCUS to diagnose soft tissue infections, I'll leave you with the findings from this recent study I found during the literature search. All right, so let's meet our last patient. Our last patient is a 22-year-old female with sudden onset shortness of breath and pleuritic chest pain. You perform a bedside POCUS and see the absence of lung sliding. An X-ray is performed and shows the diagnosis here. You bring your chest tube equipment to the bedside and landmark in the triangle of safety at the level of the inframammary fold, as you have been trained to do throughout your residency education in preparation for a chest tube. You feel like it looks a little bit low. Inspired by a recent presentation that you saw, you grab your POCUS machine. You place your probe over the landmark site, and this is what you see. While this is a made-up case, the insertion of a chest tube in the suboptimal location below the level of the diaphragm is a known complication of the procedure. This study by Laurence et al. Looked at potential risk and how POCUS can help to mitigate this. This was an observational study of adult emergency department patients recruited through convenience sampling. The treating EM resident or attending was asked to rapidly assess and mark the chest wall with a surgical pen using landmark technique, where they would theoretically insert a chest tube. An ultrasound fellow then placed a phase array probe in the center of the site that was marked and observed through one single respiratory cycle. The primary outcome was the percentage of POCUS thoracic procedure scans that identified soft tissues such as diaphragm, liver, or spleen over one regular respiratory cycle in the intercostal space selected for the tube thoracostomy. Their secondary outcome was the average time required to perform the POCUS thoracic scan. In total, 18 residents, 1 fellow, and 2 attendings marked possible sites for chest tube insertion. There were a total of 76 quick looks with POCUS. 17% of them were positive, meaning that they saw a diaphragm, liver, or spleen over one respiratory cycle. The average time to do the procedure was 43 seconds. Scans were then reviewed by a blinded ultrasound director and had a high inter-rater reliability with a K-value of 0.95. The study's greatest strength is that K-value with good inter-rater reliability. There are some limitations of the study in that it was a very small study, and the majority of people in the study were actually residents marking the chest. That said, all of them had done ATLS, and almost 20% of the people who marked below the level of the diaphragm were senior emerge residents. In summary, don't poke the chest before prodding with the probe. All right, that's all I have. Thank you so much for taking the time to attend these grand rounds and listen to the presentation. I want to leave you with a couple take-home points. So for patients who present with cardiac arrest, remember that femoral peak systolic velocity greater than 20 centimeters per second is a good indicator of ROSC. For your patient presenting with shock, if the IVC is dilated greater than 2.5 centimeters or normal size without collapse, really think about whether or not the patient is volume overload and proceed with caution. Don't just bolus this patient 1 liter as we standardly do. Think about giving judicious boluses of fluid, such as 250 cc's, and see where you get. For patients where there's signs of RV strain on your bedside ultrasound, where PE versus pulmonary hypertension is on the differential, remember that RV thrombus and McConnell sign only rule in acute PE. They cannot rule out a PE. And the same thing with RV free wall thickness and RA to LA ratio. If your RV free wall thickness is less than 5 millimeters, chronic pulmonary hypertension is less likely. If your RA to LA ratio is equal to 1, this suggests that this is more of an acute process. If you have a patient with severe soft tissue infection, take your linear ultrasound probe to the bedside and scan quickly. If you see subcutaneous air or fascial fluid greater than 4 millimeters combined with subcutaneous thickening, this rules in a diagnosis of necrotizing fasciitis. Lastly, when performing a chest tube in the emergency department, look with your ultrasound probe first before you cut the skin.